Hello and good evening, everyone. I am Dr. Vijayanand Kelkeri, Senior Consultant at Vijai Diagnostic Center. I welcome everyone on board. Since we are continuing with the webinar series of Clinical Radiological Meet, today the topic of discussion is radiological evaluation of cavitating lung lesions. As we all doctors, most of the doctors know that cavitating lesions can be sometimes be a difficult thing, like an enigma, because some of the radiologists interpret it as cystic lesions, some interpret as cavitating lung lesions. So that there can be sometimes difference of opinion between radiologists themselves as well as clinicians and the radiologists. So since we have our expertise, Dr. Vijay Kumar sir, he's a senior pulmonologist here on board today, and he's also the chief guest for today. And we have our own Dr. Arun Santosh. He's the consultant radiologist at Vijay Diagnostic Center. I thought we can just clarify this thing and try to help as much as possible for diagnosing ourselves and also for the health, betterment of the patients. So before we start, I think I'd like to introduce Vijay Kumar sir. I don't think so he need any introduction, but I'll try to briefly introduce him. Sir graduated MBBS from Kakatiya Medical College in 1975. He's completed his MD in 1981 from Osmani University, then completed his GTCD from Osmani University, and he has been practicing since last 37 years, and that's a huge experience. And the position sir has held is Professor Pulmonary Medicine in Medicity Institute of Medical Sciences. He was also the HOD in the Department of Pulmonary and Critical Care in Apollo Hospital, Yashoda Hospital, Medicity Hospital, and he is also the faculty Government General Hospitals in Hyderabad. He was also the chairman Indian Chest Society South Zone, International Fellow of American Association of Respiratory Care in 1992, Governor American College of Chest Physicians, and so far and so more. And he was also the past president of Indian Society of Critical Care Medicine, and he is also the founder and past president of Indian Association of Respiratory Care, and he is also the founder member of Indian Association of Sleep Disorders. He sir has also contributed in the chapter on pulmonary rehabilitation in the World Clinics in 2012. He's also on the editorial board of Indian Journal of Respiratory Care. He started full-fledged respiratory intensive care unit in South India in 1995. Started the first ever DNB in respiratory medicine in Andhra Pradesh in 1997. He has delivered several orations, prestigious orations like Dr. P.S. Reddy Memorial Oration, Dr. S.R. Rao Memorial Oration, Dr. K.J.R. Murthy Memorial Oration, and Dr. Ranga Rao Memorial Oration. He's organized nearly 12 major international conferences and at least 50 national workshops in various areas of pulmonary and critical care. He is one of the principal investigators in ICMR, and he has contributed in at least 8 textbooks in pulmonary medicine and critical care medicine. He's also plays a major role in the ICMR, and he's also vice chairman TB Alert and subsidiary of TB Alert UK. That was a brief introduction, sir. And I welcome you once again on board. It's actually a privilege for me, and you are an inspiration to all the doctors all over India and world. So before we start the talk, I'll just introduce Dr. Arun also. Dr. Arun Santosh, he is a consultant radiologist. He is quite young and enthusiastic, and he's completed his MBBS from SN Medical College, Bagalkot, and completed his DNB from prestigious Nizam's Institute of Medical Sciences. So I would like Dr. Arun to take on and start the discussion for today. Okay, to you, Arun.
Thank you very much, sir. So, coming to the topic, that is the radiologic evaluation of cavitating lung lesions. Excuse me. So first of all, what is a cavity? A cavity is defined in the Fleischner glossary as a gas-filled space seen as lucency or low attenuation area within a pulmonary consolidation, a mass or a nodule. Hence, a lucent area that may or may not contain a fluid level and that is surrounded by a wall, usually of a varied thickness. At their end stage presentation, some cavitatory diseases may present with thin-walled cavities or cysts. And one should remember that there is continuous transmission of these cysts of these cavities into the cysts. Then what is a cyst? A cyst in the lungs are described as any round circumscribed space that is surrounded by epithelial or fibrous wall of variable thickness, and usually they are thin walled and that is less than 2 mm. Here we are seeing two spot radiographs. The one on this side is showing where a radiolucent area in the left apex which is having a very thin wall. Whereas same here we are seeing a radiolucent focus in the left apex which is having a relatively thick wall, and that's why we are calling it as a cavity, and this is we are calling it as a cyst. Then what is the pathophysiology of formation of a cavity? The pulmonary cavitation occurs when nodules or regions of consolidated lung undergo central necrosis or liquefaction and become air-filled. That leads to there is complete destruction and there is a surrounding band of fibrosis with a central necrotic material. It is taken from a journal where a cavity is resultant of any number of pathological processes, including the suppurative necrosis, that is pyogenic lung abscess, or caseous necrosis in tuberculosis, ischemic necrosis in pulmonary infarction, cystic dilatation of lung structures due to the bowel wall obstruction, and in pneumocystis pneumoniae, or displacement of lung tissue by cystic structures like hydatid disease. In addition, the malignant processes may cavitate because of treatment-related necrosis or internal cyst formation or internal desquamation of tumor cells with subsequent liquefaction. The likelihood that a lesion will cavitate depends on both the host factors and the nature of the underlying pathology. However, as a general rule, organisms that may cause subacute or chronic pulmonary infections, that is mycobacteria and fungi, seem to be more frequently associated with cavities than organisms that cause acute pulmonary infections like viruses and streptococcus pneumoniae. But this rule has many exceptions, as necrotizing pneumonias are also associated with acute infections of Staphylococcus aureus and Klebsiella pneumoniae. So what are the imaging modalities we generally use to see a cavity? So chest radiograph and CT are the most common ones which we are using at present. Ultrasound is not used, is suboptimally modality for the imaging of lung parenchyma because of its poor sound transmission through the mostly air-filled lungs. And magnetic resonance imaging of lung has been limited by motion artifacts and relatively low spatial resolution. So this modality is also again not used much. So here we are focusing basically on only two modalities, that is radiography and computed tomography or CT. So what are the radiological characteristics of a cavity? The major important points are the wall thickness, the characteristics of the inner contour, the internal contents, the number and location, and other associated findings surrounding the cavity, and obviously the clinical findings. So first, coming to the wall thickness. The cavities with wall thickness of 4 mm or less are usually caused by non-malignant process. The wall thickness of 5 to 15 mm are mixed, which can be caused by both malignant, that is infectious or benign conditions, and non-malignant conditions also. And wall thickness of more than 15 mm are usually malignant. A recent study found that a wall thickness of less than 7 mm was highly specific for a benign disease, and a thickness of greater than 24 mm was highly specific for malignant disease. Again, however, these thresholds are not absolute, as thin-walled carcinomas are also reported. So just a few examples of thick-walled and thin-walled cavities. Here we can see the thick-walled cavities are seen in lung abscess, vaginous granulomatosis, necrotizing squamous cell carcinoma of lung, and fungal infection like blastomycosis. Whereas thin-walled cavities are seen in again fungal infection like coccidiomycosis, metastatic lesions, non-tubercular mycobacterial infection like Mycobacterium consaceae, congenital acquired bullae, or post-traumatic cysts. The characteristics of inner contour. So next coming is the inner contour of the cavity. It can be nodular or irregular, usually in case of neoplasms, poorly defined or shaggy because of central destruction, that is corresponds in abscesses of infection, and smooth can be seen in any other etiology. Then internal content. The cavity of content is of little help in differentiating benign and malignant lesions. Example, a benign bronchogenic cyst may contain fluid levels as a bronchoalveolar carcinoma also. The degree of contrast enhancement in the content of nodules, that is less than 10 HU, is shown to indicate benign lesions and may be used to distinguish aspergillomas from lung cancers. Then coming to the number and location. Some locations guide to the etiology of cavitatory lesions, that is upper lobes are typical for tuberculosis, as we all know that because of the ventilation perfusion ratio at the apex, the upper lobes are commonly the site for Mycobacterium tuberculosis. The solitary cavitatory lesions are found in lung abscesses, neoplasms, or post-traumatic cysts, and multiple cavitatory lesions are seen in infections and autoimmune disorders like Wegener's and rheumatoid, and obviously metastasis. And other associated findings surrounding the cavity, like the cavities may be associated with surrounding ground glass attenuation or surrounding nodules, that is pulmonary opacities, and background interstitial lung disease in case of RA or any other conditions. An additional indicator of malignancy is generally a lack of perilesional centilobular nodules, whereas perilesional consolidation was common around the benign cavities. Then whenever we see a cavity, we have to just see the duration of evolution, that is acute or subacute. Acute or subacute are generally seen in pulmonary infections, that is generally by the bacterial or fungal, and chronic infection, chronic lesions, that is chronic duration, is generally seen in the tubercular infections and in malignancies. So just as a mnemonic to remember what are the causes of a cavity, the mnemonic itself is a cavity. That C contributes for cancer, A for autoimmune, V for vascular, that includes the septic pulmonary embolus, I for infection, either it is bacterial or fungal, T for trauma, pneumatococcus, and Y, which is for congenital. So in cancer, the most common malignancy which undergoes cavitation in lung cancer is the squamous cell variant. And even the cavitatory pulmonary metastases are also from the squamous cell variant only. The autoimmune conditions, the granulomas which are we commonly see which undergo cavitation are in Wegener's granulomatosis, that is granulomatosis with polyangiitis, and rheumatoid arthritis, where we see the rheumatoid nodules, and they also undergo the cavitation. And in vascular, we can see both bland thrombus or a septic pulmonary emboli, which can undergo cavitation. In infection, that is a bacterial or fungal, we can result in pulmonary abscesses and pulmonary tuberculosis. And trauma will result in pneumatococcus. And the last factor is that is the congenital, which these are cyst-like lesions, that is CPAM, congenital pulmonary AL5 malformation, pulmonary sequestration, and bronchogenic cyst. So first we will come to neoplasm. The primary is a neoplasm. These are generally seen as an isolated cavitary lung lesion. The lesion will be of variable size, irregular or speculated margins, thick walls more than 15 mm, and generally associated with mass or other findings, and air fluid levels may be seen. This is a spot radiograph of the chest. Here we are seeing a well-defined radiolucency in the left lower zone, and the corresponding here the CT axial section in the lung window, we are seeing a well-defined cavitatory lesion with irregular internal margin and surrounding speculation. So this was turned out to be a squamous cell carcinoma. This is another radiograph. Here we are seeing a well-defined radio opacity in the left mid zone, which the zoomed up image shows the lobulated contour of the lesion extending up to the periphery. And here we are clearly seeing an air fluid level, that is the air at the above, and there is soft tissue opacity at the base. This was another case of smoker, where we are seeing a well-defined thick-walled cavitatory lesion at the towards the pleural aspect. Here we are seeing an inner irregular margin with peripheral speculations, and on the mediastinal window we can see there is a fluid in the dependent portion with air in the antidependent portion. This was turned out to be an adenocarcinoma. This is another case, a 50-year-old male who presented with recurrent cough. Here we are seeing a well-defined radio opacity in the right lower zone with a central cavitation. The corresponding axial CT chest in the lung window, he is showing an irregular cavitatory lesion extending up to pleural aspect. There was no smoking history or anything. This was thought to be a squamous cell carcinoma, but finally turned out to be a lymphoma. This is another case of a 50-year-old male who was presented with recurrent bouts of cough, progressive cough. These are the axial sections of chest in lung window, where we are seeing multiple discrete and confluent nodular opacities, which are showing, most of which are showing cavitation scattered all around the lung parenchyma in both the lungs. And corresponding PET CT image shows these lesions are showing significant uptake, and FNAC proved to be it as an bronchoalveolar variant. This is another case of chronic cough. Here the radiograph shows a well-defined rounded soft tissue opacity in the right lower zone with a central lucent area, whereas the corresponding CT image in lung window shows the well-defined soft tissue focus with a speculated margin and surrounding fibrosis with a central cavitation. FNAC proved it to be a malignant etiology. Next, coming to metastasis. So metastasis can be of multiple and can be of variable sizes. These are thick or can have irregular walls, as commonly seen in metastasis from an adenocarcinoma, and thin-walled cavities will be seen from a primary squamous cell variant, and cavitation is more common in upper lobe. 70% of the metastasis are cavitating metastasis are caused by again a squamous cell variant. Other primaries that are include from the gastrointestinal adenocarcinomas, breast, bone, transitional carcinoma of urinary bladder, cervical cancers, and sarcomas. Cavitating pulmonary metastases have also been reported to develop after chemotherapy, secondary to tumor necrosis or a valve effect on adjacent bronchi. This is a frontal radiograph of chest. Here we are seeing a well-defined radio opacity in the right lower zone, partly silhouetting the cardiac margin. Could be a primary lung malignancy. If you see clearly here, there is another small radiopaque focus with central lucent area, and another similar lesion here in the left perihilar region in the central lucency. So this was probably thought as a primary CA lung of a squamous cell variant with a metastatic lung lesions in both the lungs, which are showing cavitation. This is another case of pancreatic adenocarcinoma, where we are seeing multiple discrete and confluent nodular lesions scattered in both the lungs, few of which are in peripheral and subpleural location, and few of which are also showing the cavitation. Like here we are seeing the posterior aspect of the left lower lobe. And these are the solid metastatic lesions from the pancreatic adenocarcinoma. This was a case of CA breast, where we are again seeing multiple nodules, rounded nodules, discrete and confluent, scattered in both lungs, and few of which are in subpleural location, and few of which are again cavitating here in the left lower lobe and the right lower lobe, and here again in the right upper zone. Then coming to the infectious pathology, that is necrotizing bacterial pneumonias, generally caused by Staphylococcus aureus, gram-negative bacteria, and anaerobes. Primary consolidation that can be associated with cavitation inside. In anaerobic bacteria, it is common to develop abscesses with thick and irregular walls and can contain air fluid levels. This was a 35-year-old male who complained of recurrent bouts of fever and cough, non-resolving for the last 15 days. So CT was done, and this is the axial section of CT chest in mediastinal window post-contrast. Here we are seeing a well-defined consolidation in the anterior segment of right upper lobe, which is showing a central area of breakdown with internal debris, and we can see a small rim of peripheral enhancement, and there is dependent fluid over it. We are also seeing patchy consolidation surrounding this bigger consolidation, and associated we can see this arrow showing this syn pneumonic effusion. This is a frontal radiograph of chest in a patient who had undergone renal transplant 5 years ago, presented with fever with cough for the last 15 days and high grades of fever. Here we are seeing a well-defined radio opacity in the left upper zone, probably a consolidation in the left apex. The following which CT was done. These are the axial sections of CT chest in lung window and the mediastinal window, where we are seeing a thick-walled cavitatory lesion with internal debris and a small air fluid level. And what is seen here is a peripheral ground glass consolidation surrounding the cavity. So this again turned out to be a bacterial pneumonia which has undergone breakdown with an pulmonary abscess. This is a child who presented with high-grade spikes of fever and cough. This frontal radiograph here we are seeing is a thin-walled cavitatory lesion in the right lower zone in the perihilar region, and again we are seeing a relatively thick-walled radio opacity with an air fluid level here in the left, mid, and lower zones. The corresponding CT image was done here, where we are seeing a very thin-walled cavitatory lesion in the right lower lobe with a few thin internal septae, and a relatively thick-walled cavitatory lesion in the left lung, which is showing an air fluid level. So culture showed this turned out to be a Staphylococcal aureus pneumonia, and following which, as the patient was very severely as I already told, the patient was an immunocompromised patient. The follow-up CT was done after 5 months, which showed the shrinkage of the pneumatocoel on the left side with surrounding fibrotic changes. But the patient was still having cough, recurrent bouts of cough, and when it was investigated, this turned out to be a soft tissue content within the residual pneumatocoel of the prior infection, and this showed out to be an aspergilloma in a prior pneumatocoel of a Staphylococcal aureus infection. This is another child who presented with recurrent fever and cough. Here we are again an axial section of chest in a lung window. We are seeing a dense consolidation involving almost entire right upper lobe and with surrounding ground glass areas. And what we are seeing is well-defined areas of cavitation with air fluid level within the dense consolidation. These turned out to be Klebsiella pneumoniae. And again, this is another patient of a Klebsiella pneumoniae who had prior pneumatocoels, and these are the follow-up CT scan after 6 months, which showed shrinkage of the pneumatoceles, but residual pneumatoceles with surrounding fibrotic changes. This was again a child who was a known case of ALL, who presented with who was on immunosuppression and who presented with recurrent bouts of chest infection. So the frontal radiograph obtained the first visit showed a well-defined radiopacity almost obscuring the entire right hemithorax with no significant mediastinal shift. And here we can see the chest drain in C2. If a radiograph obtained 5 days later showed there is a reopacification of the lung with well-defined air fluid levels in the reopacified lung. And here we are seeing the drainage tube. Probably it has drained the fluid, and the corresponding coronal and sagittal deformated chest images in the lung window shows well-defined cavitatory lesions with thin internal septations. These are the sagittal images where we are seeing the air fluid level. Two well-defined cavities are seen here, and here this one and this one, and surrounding associated consolidation is also seen here, a part of it. So this turned out to be a Streptococcus pneumonia infection. So we saw Streptococcus pneumonia, Klebsiella pneumonia, and Staphylococcus aureus, all these causing pneumatoceles and cavities in children. Next, coming to post-primary tuberculosis, which is there is presence of infiltrates. Here the cavities are having the presence of infiltrates with multiple satinate nodules and cavitatory lesion, located frequently in upper lobes and apical segments of lower lobes. They widely vary in size, both thick and thin walls. Inner walls can be smooth or more irregular and thick. This is a frontal radiograph of chest who was a sputum positive TB. Here we are seeing a well-defined thin-walled cavitatory lesion on the right, and again here also we are seeing another relatively thick-walled cavitatory lesion on left. These are the axial corresponding mediastinal window and the lung window. We are seeing the cavitatory lesions, thick-walled cavitatory lesions in the bilateral apices, and a small focus of calcification on the left side. Fungal infection next. The most common is the Aspergillus infection. The cavitatory lesions can be of variable wall thickness. In aspergillosis, thick-walled cavities are generally isolated or multiple in upper lobes associated with focal surrounding opacities and infiltrates. Generally, we see two signs associated with fungal infection, that is air crescent sign and halo sign. This is a frontal radiograph of chest in a known case of old PTB patient. Here we are seeing a well-defined radioopacity with fibrotic changes and traction ipsilateral mediastinal shift towards right side. Here, excuse me, there is a well-defined radioopacity in the right upper zone with an air crescent sign. Here we are seeing a surrounding rim of air at the periphery. Corresponding CT images in lung window and the mediastinal window, we are seeing there is a well-defined fibrosed area in the right apex with a cavity, and the cavity is showing a well-defined round internal content and a peripheral rim of air surrounding it. This is the air crescent sign. This is another case of again a post-tubercular cavity with an internal content, that is aspergilloma with an air crescent sign. This is another patient who was a known case of PTB. Here again we are seeing multiple, this is a radiograph where we are seeing multiple well-defined cavities with a soft tissue content and a peripheral rim of air. This one lesion, again another lesion, and again another lesion in the left lung. Almost 3 lesions we are seeing. And this is another CT image where we are seeing a well-defined cavitatory lesion with surrounding nodules and a central inside the well-defined internal content and a peripheral rim of air, that is giving the air crescent sign. So these are generally an fungal infection, that is aspergilloma is generally formed in a pre-existing cavity, commonly in India seen in a mycobacterial infection. Whereas this was a case of immunosuppressed patient where we see a well-defined soft tissue density lesion in the posterior basal segment of right lower lobe with surrounding ground glass attenuation. The culture showed it to be a fungal infection, that is aspergillosis. So in view of the immunosuppressed state of the patient, this was considered as an invasive aspergillosis. And the surrounding ground glass attenuation around this lesion is due to the hemorrhagic infarction caused by the fungal infection. Subsequent CT done 3 months later showed the cavitation in the pre-existing soft tissue lesion with a well-defined central round focus and mild surrounding ground glassing. Again, the CT was repeated after 6 months, which showed the subsequent resolution with shrinkage of the cavity with a small residual cavity. This was a proven case of invasive aspergillosis in a immunosuppressed patient. So what are the DDs for air crescent sign? Generally, we see in aspergillosis, that is aspergilloma, lung abscesses can be seen in bronchogenic carcinoma or a TB cavity with Rasmussen emphysema and a hydatid cyst. Next, coming to autoimmune disorders. The common cavitating autoimmune disorders which we see here in lung are the Vijayanand granulomatous. So, Vijayanand granulomatous is a systemic necrotizing vasculitis which affects both the upper and lower respiratory tract and manifests as a multiple bilateral nodules or masses which may cavitate by themselves or by necrosis secondary to arterial occlusion. This was a 45-year-old female who had both upper and lower respiratory tract symptoms, and the upper respiratory tract patient was having recurrent sinusitis, following which recurrent lower respiratory tract symptoms are also existing. So a chest radiograph was obtained, and chest radiograph shows multiple cavitatory lesions around 1, 2, 3 are almost seen in the right, mid and lower zones, and a thick walled cavitatory lesion again is seen in the left mid zone. So for the corresponding, following which the CT was obtained, these are the images in the mediastinal window and the lung window. Here we are seeing a patchy consolidations in the right middle and lower lobes, and these and even we are seeing a well-defined cavitatory lesion even in this consolidation in the right middle lobe and a well-defined cavitatory lesion in the left upper lobe. So these are the corresponding images in the lung window again, and we are also seeing a small right pleural effusion. This is another case of Vijayanand granulomatosis with recurrent lower respiratory tract infections. Here we are seeing a thick-walled cavitatory lesion with a central lucency. Corresponding axial CT chest in lung window shows a well-defined cavitatory lesion with again an air fluid level in the anterior basal segment of right lower lobe. We are also seeing a well-defined soft tissue nodular opacity in focus in the right middle lobe also. So these were proven to be a case of Vijayanand granulomatosis. Next, coming to rheumatoid arthritis, it affects mainly in the women in the age of 20 to 50 years. And here also we can see bilateral multiple lung nodules, usually small in size and subpleural location that may cavitate. This is a frontal radiograph of chest again in a patient of known RA. Here we are again seeing multiple cavitatory lesions predominantly in the right lower zone and the mid zones. And again here also we are seeing multiple cavitatory lesions in the left, mid and lower zones. This is the axial CT in the lung window. We are seeing multiple pleural based nodular lesions and many of which are cavitating. So this is again a case of rheumatoid nodules which have undergone cavitation. Next, pulmonary infarction. Lung infarction that can also cavitate due to necrosis and unique with subpleural location and triangular morphology with apex directed towards the hilum. These cavities may be present for a long time until their complete resolution. Next, coming to septic emboli. Typically, they appear as nodules in the lung at the periphery. Wedge-shaped peripheral lesions and infiltrates are also seen. And one of the signs which is described with septic emboli is a feeding vessel sign. This was an immunocompromised patient who had recurrent bouts of fever. The frontal radiograph shows multiple cavitated lesions. Like here we can see a well-defined radio opacity in the right perihilar and left perihilar and left lower zone regions. And the corresponding CT image, here we are seeing the zoomed up image showing a well-defined peripheral based nodular lesion and a vessel which is seen tracking up to the lesion. So this is the feeding vessel sign where the bacteria or the septic focus has embolized from the primary bloodstream into the peripheral lung parenchyma, and that is the feeding vessel sign here seeing. Again, these are the coronal reformated images in another patient of septic emboli where we are seeing peripheral based nodular foci with areas of cavitation. In another case of organizing pneumonia, they manifest as a ground glass opacities. In some cases of organizing pneumonia, can also have a small areas of cavitation with patchy areas of consolidation and peripheral distribution that may cavitate, but these findings are not specific. Here, these are the axial sections of CT chest in prone position, and here we are seeing a well-defined patchy consolidation in the posterior basal segment of left lower lobe, and the small area of early cavitation is seen, and few fibrotic bands are seen in the adjacent lung. Next, coming to cavity-like or cystic lesions, in which we are seeing just a parasitic lesions, that is a hydatid cyst of the lung. They can appear as homogeneous masses on plain X-ray. If air penetrates between the cyst wall or and the cyst, a cavitatory appearance may be seen. And few signs are described with hydatid cyst, that is the crescent sign, meniscus sign, and water lily sign. This is a frontal radiograph of chest where we are seeing a well-defined rounded radio opacity in a well-formed hydatid cyst case. And here these are the again another case of hydatid cyst where we are seeing well-defined rounded opacities which are almost solid in the right lung, whereas the lesion in the left lung is showing an air fluid level. This is giving the meniscus sign. And here this is another patient who is a known case of hydatid cyst. Here we are seeing a well-defined radio-opacity in the left lower zone. And here if we see closely, there is a crescent of air at the superior part of the lesion. And this is a lateral radiograph projecting the same. So this is giving a crescent sign. This is another case of hydatid cyst where we are seeing a thick-walled cavitated lesion in the right lower zone with collapsed membranes. Corresponding CT image reveals the same with a thick walled cavitated lesion and the collapsed membranes. This is another case of hydatid cyst where we are seeing a thick-walled cavitated lesion showing an air fluid level, and these are the membranes which are floating in the fluid in a recently ruptured cyst, so giving a water lily appearance. When the fluid gets resorbed, these cysts become the internal debris get placed at the dependent position of the cyst, and slowly these contents of the cyst will get expectorated and the cyst may become completely cleared over a period of time, and only a residual cystic wall may be left. And traumatic, to include in the list, the traumatic, that is traumatic pneumatoceles can be of variety of sizes and appearances. Thin walled cystic spaces within the lung parenchyma containing air, smooth and regular margins, contain little fluid if any, and persist despite absence of the symptoms. This is a young male who had trauma, and here we are seeing multiple pulmonary contusions, and one of the contusion here we are seeing is showing well-defined rounded cystic areas of degeneration within the lesion in the posterior basal segment of right lower lobe. This is another case of post-traumatic pneumatocele. Here we can see in the axial sections of chest in the lung window, we are seeing bilateral pneumothoraces. Here bilateral pneumothorax is seen, and multiple large pulmonary contusions or hemorrhages are seen scattered in both the lungs, and these areas of contusions are showing well-defined air fluid levels over a period of time. Next, to finish the list is the congenital. That is, in congenital we include the congenital pulmonary ALFA malformation. These are present as a multicystic intralobar mass of disorganized lung tissue. 70% are present in the first week of the life, and 10% of the first year. May demonstrate a multicystic air-filled lesion on the chest X-ray. This is the frontal radiograph of chest in an infant, where we are seeing a large, well-defined radiolucent area of, involving almost entire right hemithorax and causing mass effect and mediastinal shift towards the left side. Corresponding CT chest in the lung window, we are seeing a multicystic lesion with a few internal septations, and there is shift of mediastinum to the left. This is another radiograph where we are seeing model lucencies in the right hemithorax, and the corresponding axial CT chest shows intercommunicating multiple cystic lesions involving almost entire right lower lobe. This was a case of CPAM. Then to conclude this, lastly we will see about the pulmonary bronchogenic cyst. More common is the intrapulmonary bronchogenic cyst. This bronchogenic cyst also can be seen in the mediastinum, but this is an intrapulmonary bronchogenic cyst, more common in the medial lung or lower lobe, sharply circumscribed, round or oval shaped, air or fluid filled, thin wall, and occasionally calcified. This is a 35-year-old male who actually presented just for a checkup, and sometimes recurrent bouts of cough, and where we are seeing a well-defined radiolucency involving almost entire right hemithorax in the right mid and lower zones, but there was no significant mediastinal shift, and axial CT chest was obtained in mediastinal window post contrast, showing a well-defined thin walled lesion with no significant signs of surrounding inflammation and a fluid level within it. Final histopathology proved to be an intrapulmonary bronchogenic cyst. This is another case of intrapulmonary bronchogenic cyst. Here we are seeing the frontal radiograph, where we are seeing a well-defined cavitatory lesion in the right suprahilar location with an air fluid level. Similar corresponding axial CT chest in the lung window, we are seeing a thin-walled, very smooth cavitatory lesion with an air fluid level with no surrounding inflammatory changes or any nodules. So these are the axial MR images in the T1 and T2, where we are seeing a signal void at the above with an T1 hypointense contents and T2 hyperintense contents, internal contents. This was finally proven to be an intrapulmonary bronchogenic cyst. So to conclude, these cavitatory pulmonary lesions are caused by a number of varying disease entities, as we already seen. So paying close attention to the disease-specific radiologic findings combined with the clinical history and findings are important tools leading to correct diagnosis. So these are my references. I thank VDC team and Dr. L.T. Kishore sir and Vijayanand sir for giving me this opportunity to present in this platform. Thank you.
Yeah. That was a very nice presentation, very elaborate presentation, but concised very nicely with the very good examples of CT and chest radiograph. Uh, sir, Vijay Kumar, sir, can I just ask you to tell what are your day-to-day uh, difficulties when you find such patients in your daily life? First thing, and second thing is, what are the things which you would like to ask Arun while he presented, because there can be some amount of definitely discrepancies can be there, which you must have noticed. Anything, sir?
Yeah, very nice presentation, good summary and a good review of all the cavitary lung diseases. And I thank Vijay Diagnostic Center for organizing this wonderful webinar and also inviting me to take part. And one of the things, uh, as soon as we get an X-ray of a patient which shows a cavity, it there is a challenge. The challenge starts, and the urge to make a perfect diagnosis will begin. So, like you said, the diagnosis doesn't always rest only with radiology, but it is a combination of radiology, lab, clinical history, all put together. Each area will play an important role in coming to a conclusion. Of course, there are certain radiological features of certain cavities or cysts where you don't have to do any further investigations, and then you can make a diagnosis, like LAM, lymphangioliomatosis, then Langerhans cell histiocytosis. They are so obvious. You don't have to do any further investigations. But then there are certain cavitary lung diseases where you need a lot of supporting evidence and a lot of history. And one of the cheapest and very important thing that we should ask the patient is to bring if there are any old X-rays. So if he has an X-ray which was done, let us say 5 years back, and it shows the same lesion, then it goes to show that it is a very harmless benign lesion, maybe even congenital. So your 90% of the work is done the moment you see the same lesion in the old X-ray. So asking the patient to get an old X-ray or a old CT scan is very important. Then again, as you rightly said, clinical history, for example, fever, chest pain, they always indicate infection, inflammation. And you said about acute and chronic. Again, history and duration are very important. If the patient says, "Sir, Sunday I was okay, I attended a party and I was hale and hearty. But Monday morning when I got up, I started with a fever, with chills and rigors, and I had a chest pain." And now you know that it is an acute situation. Maybe a community acquired pneumonia, maybe a streptococcal pneumonia, because fever with chills and rigors usually happens with streptococcus pneumonia. And then if this patient comes to you maybe after 10 days being treated elsewhere with some painkillers and things like that, and then X-ray shows a cavity, you know that it is a cavitating pneumonia. Similarly, many of the times we miss the history of trauma, because Arun mentioned about trauma-related pneumatocysts. So sometimes patients forget to mention about the trauma. It could be a fall from the scooter or fall from the chair or something like that. We have to specifically ask. And again, history of smoking is very important in these patients, because if he is a smoker of 15, 20 cigarettes for the past 20 years, then the in the differential diagnosis, malignancy comes number one. So squamous cell carcinoma, as Arun rightly mentioned, is very notorious to produce cavities. Even metastatic lesions of malignancy can produce cavities. Again, squamous cell carcinoma is very notorious. and metastasis coming from breast, GIT, or very notorious adenocarcinomas also can produce cavitating metastasis. Then, of course, the contents inside a cavity, he made a nice mention about aspergilloma, clot, Rasmussen's aneurysm, etc. One of the things that would help in radiological evaluation is to do a right lateral or left lateral Trendelenburg position and then take a X-ray or a CT scan. That will tell us whether the content inside the cavity is moving or not. If it is changing the position, then the answer is very clear. It is either an aspergilloma or a clot. And again, if you are doing a CT scan, if the Hounsfield units are less than 10, that goes more in favor of a benign pathology rather than a malignant pathology. So when you are doing if the lesion is on the right side, you can do a right lateral Trendelenburg, and then you can put a couple of pillows under the pelvis and lift the pelvis, and so that um, it is called Muller-Lofted position. So it will show a very clear cut that the entire content will move towards the top of the cavity in that position. Then it becomes very clear it's a something moving inside the cavity. Then one of the big questions for the clinicians is when they see a cavity, and tuberculosis is one of the very important differential diagnosis, especially if one of the family members had active tuberculosis in the recent past. So there we take the help of the lab, and we do a sputum for acid fast bacillus and sputum for gene expert or CBNAT, which should be a early morning specimen. Here we have two varieties of tuberculosis. One is the regular tuberculosis, and the other one is the non-tuberculous mycobacterium. In a non-tuberculous mycobacteria, the AFB may come positive, but the gene expert will come negative. That's a very important indication that what we are dealing with is a non-tuberculous mycobacteria. Plus, this gene expert or CBNAT also will tell us whether we are dealing with a drug-resistant tuberculosis or not. Because gone are the days where we used to start anti-TB drugs, then 2 months, 3 months, 4 months later, we realize that the treatment is not working, patient is not getting better, and what we are dealing with is a drug-resistant bacteria. But now we do that on day one, even before starting the first drug. We do a CBNAT, and the CBNAT will tell us whether patient has got rifampicin resistance or not. So clinical, radiological, and mycobacterial or a bacteriological evaluation are so important. Then Arun mentioned about tuberculosis cavities, especially in the upper zones, but the TB cavities can also happen in the lower zones, especially in immunologically compromised people, in diabetics, in immunologically compromised people like those who are receiving chemotherapy, and also it can happen in children and young females. Lower zone tuberculosis is very notorious. So these are some of the takeaways from my clinical experience, adding a few more things to Arun's talk.
Thanks, sir. Thanks a lot. It's always a pleasure interacting with you, sir. And I have a question for you, sir. Recently, we have just thinking that we are just past the COVID era. There, we could see there were some patients coming with cysts and also some cavities. How difficult was it to treat such patients, sir?
Yeah. Uh, at no time in the history of medicine we have done so many CT scans as we did it during the COVID pandemic. I have not prescribed as many HRCTs as I did during the COVID pandemic. And as a result, we were in for a surprise we found out there were a lot of patients who had congenital problems, which would have been ignored if he did not come for COVID treatment. And there were many people who had tuberculosis. In fact, World Health Organization said one of the um, important diseases which got a bad treatment during the pandemic is tuberculosis, because a lot of patients with tuberculosis got missed during the pandemic. And there was a coincidental tuberculosis in these patients or soon after COVID treatment because of the high doses of steroids. Third thing, of course, the sequelae because of the COVID itself. Notoriously, there were a lot of review articles which talked about this sequelae. Notoriously, post-COVID interstitial lung disease was there, but in many of these people, if you watch carefully, clinically, radiologically, and also by the pulse oximetry, these patients used to get better spontaneously without any further treatment on their own. But then there were some patients who continued to have symptoms, continued to have hypoxia, and in those people, we had to start some prolonged steroids or antifibrotic agents. And in the same breath, I can also mention that some of these patients also had cysts, like you mentioned. Um, we are not very clear whether these cysts were pre-existing or were a result of the COVID. But then I think if the patient is asymptomatic, not breathless, probably we have to keep watching these patients with every 3 months CT scan.
So, actually, in fact, I thought there were multiple, like many cases which were pre-existing diseases came to know only because of the COVID. Not only these benign lesions, we could even see so many patients coming with incidental malignant lesions. So, for a few people, I think it was a blessing in disguise whoever recovered from COVID. Okay, that's it, sir.
We all got sufficiently educated in interpretation of HRCT
Yes,
because
sir.
of the pandemic.
Yes, sir. Okay, sir. I think we are already overshot our time, sir. We don't. I don't see any other this audience questions also there. And I once again thank Vijay Kumar sir for being the chief guest of honor for today and also educating us and all the people who are listening the talk on behalf of myself as well as Vijay Diagnostic Center. Thank you very much, sir. And Arun, thanks. It was a very nice presentation.
Thank you.
Thank you.
Thank you so much.
Thank you.